thousands of patients currently at risk. He says a lot of very important things in this article, but the one that struck me the most, which is important for clinicians to understand, is this middle statement. The types of study designs that we are going to need to satisfy the American College of Cardiology and other governing boards have yet to even be instituted. So we're looking at years down the road before people are going to give the kind of go-ahead on this that some people will look for. There are other people that feel that there is more than enough information about this to integrate that into the care of their patients. Now, the American College of Cardiology Foundation Task Force and the American Heart Association recently published in June or early July a clinical alert to discuss these issues about this black box warning. And this is what they had to say. Serves to make clinicians aware of the imperfect but significant knowledge that we have about genetic variations in response to clopidogrel, and to emphasize that clinicians should use this knowledge to make decisions about how to treat individual patients. Now, I think this comes down to I think that this statement, and I'm going to conclude here, this statement comes down to one phrase that I think represents the push-pull between those physicians that are taking care of patients and people that are involved in generating decision-making about how we tell other physicians to practice, is that phrase, imperfect but significant. And I focus really on what is imperfect. And that's where the controversy lies, and that's what we will have to resolve over the next years. For some people, there is more than enough perfection to the knowledge that we have that we should start integrating this into the way we take care of patients. For others, it's still imperfect. So we'll have to see how that evolves. At this point, I think that as we look, thinking about what Dr. Wu had to speak about when we gave this talk a couple of days ago, he talked about functional tests. There's a variety of tests that can look at platelet aggregation, and those tests are kind of competing. In that situation, instead of looking at genotype, we're really looking at phenotype. In other words, how are the platelets actually working in that individual patient? This provides us a different characterization of dosing and a different characterization of that patient. And I think ultimately we're going to see that the best management is going to be an integration of platelet function studies along with genotype studies to evaluate which drugs we should pick and which dosages we should use. The important thing, just to finish this up, is that we also have a variety of algorithms. The algorithms are not that complicated, and this is what makes 2C19, I think, a more interesting situation than I think warfarin, in that all we really need to do is look at the patient, determine if the patient has a reduced function polymorphism. Do they have two alleles or one allele? If they have two, then we might want to consider using a completely different drug. If they have one, we could consider just doubling the dose into that 150 milligram range, or for loading, that 600 milligram range, and feel comfortable that we've adequately protected them. So that concludes my comments about clopidogrel, and I'm going to turn it over to Pat Dillon, and we'll be talking about KRAS and BRAF.
Thank you. I'm going to talk today about KRAS.